Hi folks, and welcome to this class which we are going to have on influenza. As you know, today with flu being there present everywhere, we are all speaking about the flu epidemic. But flu has not been a new epidemic. Flu has been with us since ages. We'll discuss this. Today we will be discussing only influenza as it was earlier, and I will be taking a class on coronavirus or COVID-19 later. The reason I plan to take this later is because we have such a large number of changes coming on daily regarding COVID-19, and I'm sure all of you must be going through various things which are being put up by the ICMR on COVID-19. Please do that, and we will have a discussion possibly in the month of June or so, when we will discuss in detail about COVID-19. Do remember that COVID-19 will be a very important question as far as your exams are concerned. Now let's see what influenza, what we knew it as we knew it earlier. Influenza is commonly referred to as flu, and it is caused by the RNA viruses of the orthomyxoviridae group. And as you are aware now that we have seen such a lot of on YouTube as well as various other channels about the current influenza flu epidemic or pandemic. Influenza is present and affects various animals, birds and animals. We are aware also that the current COVID situation was possibly from animal market which was there at Wuhan. So what does it consist of? Normally the common symptoms of influenza are chills, fever, sore throat, muscle pain, severe headache, coughing, fatigue and general discomfort. All of this is confused with other influenza-like illnesses, especially common cold. Common cold also gives you the same symptoms. You have chills, you have a fever, you have a little bit of muscle ache, headache, cough. So common cold and influenza have similarity, but influenza generally is more severe. The WHO defines influenza as a viral infection that affects mainly the nose, throat, bronchi, and occasionally lungs. So infection usually lasts for about a week and is characterized by sudden onset of high fever, aching muscles, headache, and severe malaise, non-productive cough, sore throat, and rhinitis. So if you really go to see, these are similar symptoms to common cold. When you look back at history, influenza can be traced as far back as 400 BC. And Hippocrates described a cough outbreak that occurred in 412 BC in Turkey. In the 17th century, we had an influenza epidemic which infected 2/3 of the Rome's population and 3/4 of Britain's population. Later, the disease spread to North America, West Indies, South America, and ultimately culminated in New England, New York, and that was in 1789. The 1781 marked the beginning of various epidemics and pandemics which took place of influenza. So let's look at the various pandemics or epidemics which have taken place. And one of the biggest ones which is now being talked about is the Spanish flu. The Spanish flu per se did not start in Spain. Yes, the Spanish flu actually started in China again. And we will talk about Spanish flu. When we talk about COVID, we'll talk about Spanish flu in detail. See, the Spanish flu is known as Spanish flu basically because of the fact that the rest of the countries were at war and they had a sort of censorship and no data about illnesses was being sent around. But Spain was not in the war, was reporting the cases, and hence people knew about that there was a flu in Spain. They did not know that the flu was there all over the world. So that's how it came to be known as Spanish flu. Okay. Then that was in 1918 and went on till 1921. And we had penicillin was discovered in 1928, not that it affected flu, but the influenza virus was identified in 1931, and we then had various grades of people trying to develop a vaccine. The first vaccine was developed in 1942, and then we had in 1957 we had what is called the Asian flu pandemic, which killed about 1 million people worldwide. And again, another epidemic which started from Asia, Hong Kong pandemic, which was in 1968. We've been trying since a long time to develop a treatment for flu, and so that's the reason why in 1993, when zanamivir was used and was effective against influenza A and B strains, that was a major breakthrough. Then in 2009 we had the swine flu pandemic, which again killed about 280,000 people worldwide. So we've been having these pandemics. It's not that COVID-19 is some new it is a new pandemic, but we've been having, flu has been causing problems all over the world. Fortunately, flu has not been causing so much problems in India. Oh, well, this is one of the slides of the flu pandemic which took place in 1918. The seasonal flus or common flus which are there are respiratory illnesses which can be transmitted from person to person, and most people have some immunity, and there is a vaccine available. We'll talk about this in detail. Pandemic flu as such is a problem. It's a virulent human flu which has which, as the word suggests, is a pandemic. Pandemic means it covers more than it covers the number of countries, and is of serious nature. So people don't have natural immunity to it, and it can spread easily from person to person. So there are two other words which I would like to introduce. That is, one is avian flu or bird flu, caused by the A1 virus, which is there by influenza viruses naturally available in wild birds. It is low pathogenicity, and it is common in birds. The H5N1, which was a pathogenic variant of the A1 flu, was deadly to domestic flus, and there was a species jump which took place from birds to humans, and was again deadly among humans also. Since there was no human immunity, human vaccine availability is also very limited. Then the swine flu also, which we talked about, the 2009 epidemic which was there, where you had respiratory disease of pigs of the type A influenza virus. Normally outbreaks occur in pigs, but then jump of species and humans got infected, and this resulted in another epidemic. So generally these pandemics seem to be occurring every 15 years, 10 to 15 years, and many of them are due to changes in the virus, as we will discuss. These epidemics have a sudden start, they have a short incubation period, large number of subclinical cases, short duration of immunity, and no cross immunity between various virus strains. So what are the epidemiological determinants of this disease? The influenza virus, as I mentioned, came from the group family which was the Orthomyxoviridae. The three viral subtypes, type A, type B, and type C. And these three viruses are antigenically distinct. There is no cross-immunity between them. And we actually are concerned with A and B. C is not creating much of a problem for humans. So, as I said, A, B and C, A causes major epidemics, B causes localized outbreaks, and C rarely affects humans. Now, these viruses, influenza viruses A and B, have two distinct surface antigens. One is the H, or the hemagglutinin, and the N, the neuraminidase antigen. The H antigen is the one which initiates the infection following attachment of the virus to susceptible cells. The N antigen is responsible for the release of the virus from the infected cell. So, if you see, the initiation portion, which is there by the H, and the continuation of the replication and the release is done by the N. So, hemagglutinin is a glycoprotein composed of two polypeptides, HA1 and A2, and responsible for hemagglutination and heme adsorption. Enables the virus to adsorb itself to the mucoprotein receptors and the respiratory cells. The anti-hemagglutinin is protective by preventing adsorption of the virus to the cells. The strain-specific antigen, it is capable of great variation. 16 subtypes are known, only 4 are found in humans. The neuraminidase portion, which is there, is a glycoprotein enzyme which destroys cell receptors by hydraulic cleavage, and this causes a detachment of the virus from the cell surface. And there are strain-specific antigens. 9 subtypes are known. Antibody to this antigen develops after both infection as well as immunization. And this particular antigen is not protective as far as adsorption is concerned. Inhibits the release and spread of the progeny viruses and hence can help in containing the infection. Now, whenever we write about the name of the virus, since the virus is the number of viruses which keep coming on, the subtypes which keep coming on, we have to mention the type, the place of origin, the serial number, the year, and the antigenic subtype of H and N antigens. So, for example, the virus which we got in 1968, which originated from Hong Kong, was of the A subtype, originated in Hong Kong. The serial number was 1, and the year it came in was 1968, and the antigenic subtype was H3N2. You look at another influenza A virus which started in North America, which was there in 2009. That is influenza A North America 1 2009 and H1N1. The influenza A virus is unique among the viruses because it's frequently subject to variation, and these variations can be major or minor. Now, the major variation are 2 types which are there. You can have an antigenic shift or an antigenic drift. Very important, please remember these words: antigenic shift and antigenic drift. An antigenic shift is due to a mutation which takes place. An antigenic drift is a very gradual over a period of time. So, antigenic shift appears to result from a genetic recombination of human with animal or avian virus, providing a major antigenic change, that is a mutation which takes place, resulting in a species jump. Very, very important, and this is a problem because at that you will find that humans will not have any resistance to this particular virus, what is taking place now today in the COVID situation. You had a jump, a species jump, and humans are prone to get the disease. They have no resistance in it. This can result in major epidemics or pandemics. The antigenic drift, for that matter, involves a small point mutation in the gene owing to selective selection pressure by immunity in the host population. So, the antigenic changes occur to a larger extent in the A group. In B group, it takes place to a lesser extent. And influenza C appears to be very antigenically stable and does not cause much problems in humans. Since the isolation of the virus in 1933, major antigenic changes have occurred twice. The once in 1957, that was H2N2, and again in 1968 is 3N2. Then of course again in 2009. Strains occurring between 1946 and 57 have been called H1N1 strains, and the shift which took place in 1968 with H3N2. In 1977, a new antigenic type appeared in China and USSR. The virus was in influenza A, that is H1N1. Within a year, it had spread to various countries. In the past, the emergence of a new influenza A subtype led to the prompt disappearance of the previous subtypes. But in the 1977 episode, this did not take place and the previous subtypes remained. The prevailing H3N2 was not displaced. Dual infection with both viruses were reported, and as such, now at the present moment we have three subtypes which are there: H1N1, H3N2 and B. So if you see the structure of the virion, you have got a hemagglutinin and neuraminidase which are present, and you will be studying this about the virion in detail in microbiology, so I will not go into details here. So, what are the differences between type A, type B and type C viruses? The type A virus is, the host is generally the humans, pigs, horses, birds and marine animals. While influenza B is predominantly or only solely in humans, while influenza C is in humans and pigs. So, the influenza A virus is the one which has both antigenic shifts and drifts. The more dangerous variety, the influenza A virus. Influenza B virus and C virus have antigenic drifts. The clinical features in influenza A may cause pandemics because of the fact that it has an antigenic shift which takes place and can cause a pandemic where humans are not having any resistance, and significant amount of mortalities which can take place. Mortalities can take place in young people as well as adults, the elderly, in A as well as B. While in C, you have mild disease which takes place and occurs in children without seasonality. The genome has 8 gene segments in A, 8 in B and 7 in C. And there are 10, 11 and 9 viral proteins which are there in A, B and C. The reservoir of infection which is there, as I said, is animals and birds. And many influenza viruses have been isolated from various animals, whether they be bats, swine, horses, dogs, cats, poultry, wild birds, pangolin as now is being mentioned for coronavirus. So there is increasing evidence that animal reservoirs provide new strains of the influenza virus by recombination between the influenza viruses of man, animals and birds. Source of infection is generally, if it is not a species jump, it is a case or a subclinical case. And during epidemics, a large number of mild and asymptomatic infections occur, which play an important role in the spread of the infection. The secretions of the respiratory tract are infective. The virus is present in the nasopharynx a couple of days before and a couple of days after the onset of symptoms. Now, host factors. Influenza affects all ages and people of both sexes. In general, the attack rate is lower among adults. Children constitute an important link in the transmission chain. The highest mortality rate during an epidemic, as is taking place even now, is the high risk group, that is the elderly people 65 years and above, those with comorbid conditions, diabetes, hypertension, heart disease, kidney ailments, respiratory ailments. And influenza also has a problem with infants under 18 months. Fortunately, the current virus does not give much mortality among infants below 18 months. Human mobility is an important factor in the spread of the infection. And as you've seen, infection can be transmitted from, say, China to America to Italy and to India very fast by the air route. Antibodies appear in about 7 days after an attack and reach a maximum level in about 2 weeks. After 8 to 12 months, the antibody levels drop to pre-infection levels, and that's a problem. You have to then provide some sort of immunity at that time again. The antibody to H neutralizes the virus, while the antibody to N modifies the infection. The secondary antibodies developed in the respiratory tract after infection consist predominantly of IgG. Antibodies must be present in sufficient concentrations at the superficial level, the site of the virus invasion of the respiratory tract. The environmental factors which are involved is basically the season which is involved. Season, as you know, even in India, you have the common cold virus also infects more mainly in the winter or monsoon or winter. So we have a larger number of cases which occur of influenza in the winter months, especially in the northern hemisphere. In India, we have some cases which have occurred in summer also. Overcrowding, as you know, is a person-to-person transmission, so overcrowding will enhance the infection. The attack rates are high in closed groups of populations like schools, colleges, ships. There are cruise ships now which have got infected and which have had to stay in sea for a very long period of time because of the infection being transmitted from inside the cruise ship. It's a closed environment, you have air conditioning which will possibly recirculate air and recirculate the virus. Incubation period is 18 to 72 hours. And how does what is the pathogenesis? The virus enters the respiratory tract, causes inflammation, necrosis of the superficial epithelium of the tracheal and bronchial mucosa, followed by secondary bacterial infection. But there is no viremia. Symptoms begin 1 to 4 days after infection, and you can have chills, fever, sore throat, dry cough, fatigue, malaise, muscle ache, headache, diarrhea, and dizziness. And you can also have some sort of complications like pneumonia, primary or secondary with bacterial infection, myocarditis, myelitis, Guillain-Barré syndrome, and you can have all these things that can lead to multi-organ failure and death. Studies show that a link between Ray's syndrome and use of aspirin for relieving fevers caused by the influenza virus have been noted. Disease also involves the central nervous system and liver, and children exhibit symptoms of drowsiness, vomiting, and changes in personality. So let's see the difference between cold and flu. If you see in cold you have a very, very mild fever. You may or may not have a fever. But in flu you will have a fever. There will be cold will generally give fatigue, general fatigue, body ache, mild. but all these symptoms are more prominent in flu. This fatigue which is there in cold will go off immediately after the cold goes off, but in flu it can remain for 2 to 3 weeks. It can be extreme exhaustion, and in common cold you have got more of blocking of nose, sneezing, sore throat. So these are common things while in flu these are there, but they are much less. Chest discomfort is the one which is more in flu. You've got breathlessness, you've got feeling of tightness of the chest, and followed by it going up to pneumonia. Now we do a diagnosis. Diagnosis is nasopharyngeal secretions are the best specimens obtained which give us a large quantity of viruses, and these can be tested with indirect fluorescent antibody tests, or you can do egg inoculation, and the virus can be isolated and antigenic analysis carried out. So when we do these tests, serodiagnosis, in all serodiagnosis, please remember that you should remember that the person may have had the infection earlier. So you must have a paired serum. So if you have an infection earlier, the person would already have antibodies with him, correct? So if we are looking at a repeat infection, the antibodies are supposed to increase. So you are looking at a 4-fold increase of antibodies which is there. So serodiagnosis for any of these A and B would require a paired serum, and you should take one initially and then take another, say about after another week or 10 days or 14 days after the onset. But this will be only for it will be only for educational purpose or for research work, because by the time the patient would have got treated. The titer of influenza antibodies in the human serum is so variable that only by detecting a rise in complement fixation antibodies during the course of illness can a diagnosis be established. So a 4-fold increase of titer is what we are looking at. Well, these are the few research laboratories which were having influenza virus isolation facilities. Please consider this as an incomplete list, because now with COVID-19 coming in, there are many more virus laboratories which are isolating the virus or which are testing for RT-PCR, which we'll be talking about a little later. Now, what are the rapid influenza tests? There are some rapid influenza tests which give you 70% accurate results. These things you see, these rapid influenza tests, some of them which are listed over here: direct gen flu A test, direct gen flu A plus B, or flu OEA, or quick VE, and Z-stat flu. There are various rapid tests which are available, and these provide results in 24 hours when we done in a physician's office. So what do we do for treatment? The best treatment available is symptomatic. That is rest, hydration, analgesic. Most important is hydration. Keep the person hydrated. Manage his cough. Avoid aspirin because it can lead to Ray's syndrome. And use of antiviral drugs. All antiviral drugs inhibit viral replication, but they act in different ways to achieve this. Drugs that are effective against influenza A virus, amantadine and rimantadine, and drugs that are effective against A and B, that both of them are zanamivir and oseltamivir. Now, zanamivir and oseltamivir are being used rampantly, not only for treatment but also for chemoprophylaxis, as you'll see. See, I'm listed over here as to how these are to be used, where are the indications. The administration of amantadine and rimantadine are basically oral, while you have zanamivir with oral as well as inhalation. Oseltamivir, of course, is given orally. And we have now the slide is a little lower. Zanamivir and oseltamivir is now approved for treatment as well as for chemoprophylaxis. This is a slide which gives you the various requirements of in pediatric patients which is there of Tamiflu, and you can go through this and take it down. Symptomatic drugs which are there for fever, aches, pain, sinus or sore throat is analgesics. These are over-the-counter medicines. For nasal congestion, you can give some decongestants. For running nose, watery eyes, cough, you can give some antihistaminics. And you can give some cough suppressants for cough, and local lozenges or something, or anesthetics for sore throat. How do you prevent influenza? Basically, as we said, it is transmitted by oropharyngeal transmission, and we have overcrowding is the one which is one of the features which is responsible for rapid transmission. So what we can do is good ventilation, avoid crowded places during epidemics, use cough etiquettes. As you know, earlier we used to say use your fist or use your hand to block the spray, but nowadays cough etiquette involves using your sleeve. Use your sleeve to block your droplets. But more important than all of that is use a mask. That is very important. In today's world, using a mask has become the new normal. Stay at home as far as possible after the first infection, sign of infection. Hygienic practices during poultry handling when you're looking at bird flu. And we'll keep repeating this: hand washing, hand washing, and hand washing. We have taught you hand washing during your third term. Please ensure proper hand washing practices. Teach your patients proper hand washing practices. Wash for not only your fingers, your web spaces, back of your hands and your wrists, the complete hand washing, your nail spaces, all these should be washed well, and a hand wash should take not less than 20 seconds. Vaccine is controversial for the general population, but it can be used for various high-risk groups. Which are the vaccines which are available? Most influenza vaccines programs use inactivated vaccines grown in allantoic cavity of chick embryo killed with formalin or beta-propiolactin. These vaccines are given subcutaneous. A single inoculation is usually given. However, in persons with no previous immunological experience, 2 doses of the vaccine separated by an interval of 3 to 4 weeks can be considered necessary. The protective value of the vaccine is about 70 to 90% and lasts from 3 to 6 months. Revaccination on an annual basis is recommended. The killed vaccine can produce some local problems: fever, local inflammation at the site of infection, and very rarely GB syndrome. Since the vaccine is from eggs, any person who is allergic to eggs can land up with problems and can land up with hypersensitivity. These have now been replaced by live attenuated vaccines, which are temperature sensitive, and these can be made. There are some live attenuated vaccines which have been modified as nose drops. They simulate local immunity as well as systemic immunity, and the problem is the frequent antigenic mutation of the influenza virus makes it a problem to have an effective vaccine against all viruses. So you find that almost every year we come up with vaccines for the flu virus. There are other split virus vaccines which have are also available, which are subvariant vaccines. They are highly purified vaccines, provide various much less side effects compared to the whole virus vaccines. Due to its lower antigenicity, it requires several injections. That's the whole problem which is there, that you can't do with just one injection. You require multiple injections, so you have to weigh the pros and cons and use this vaccine. Then there are neuraminidase specific vaccines, subunit vaccines containing only the N antigen, which induces antibodies only to the neuraminidase antigen of the prevailing influenza virus. The antibody to neuraminidase reduces both the amount of virus replication in the respiratory tract and the ability to transmit the virus to contacts. Next is the recombinant vaccine. The recombinant techniques which are there. The desirable antigenic properties of a virulent strain can be transferred to another strain known to be of low virulence. Efforts to improve these vaccines have been continuing. The only proven method for preventing influenza is a yearly vaccine, and this yearly vaccine is made from strains which were available in the previous year. So if a mutation takes place this year, you will still not be resistant to the vaccine. You will be resistant to strains which were available last year. The vaccine has been made from strains of last year, so you have to take it. You take it this year, before the flu season, and you have to take it at least 2 to 3 weeks before the flu season. So since the influenza vaccine is subject to genetic mutation with H and NA proteins, new vaccines that consist of different influenza strains need to be developed every year. The current vaccine which is there is a quadrivalent vaccine, meaning it provides resistance to 4 strains of influenza virus, and these have 2 of influenza A and 2 of influenza B. That's it. You cannot possibly be giving influenza vaccine to everyone, so they are given to a select population which is there, and the select population mainly consists of certain groups which are more prone to get the disease or will be critical for public services, police, fire protection, that is in abroad. In India, we recommend it mainly for the elderly. Any person who is above the age of 60 years is recommended that he should be given the vaccine. Though this is not in the immunization schedule. Please let me repeat, it is not in the immunization schedule. However, it is generally recommended for people who are elderly or who have debilitating disease or who are immunocompromised. Oh, now this slide seems to have gone awry. The H5N1 strain of virus came out in 1991. This is the avian influenza, and this came on again in 2003. There was a huge outbreak in the poultry. This is a species jump which took place and affected humans also. So 478 humans were affected in 2003 with the avian influenza. So we have, okay, this slide also seems to have gone out of the focus. So in 2009, the 2009 pandemic which took place, which started off in the US, which spread all over, the SARS epidemic, which is known as, this epidemic came on and took a large toll on the population. However, this reached India only 2011, and there were 603 cases with 75 deaths which took place in India. with a case fatality rate of 12.44%. Incubation period of this virus was 2 to 3 days and a maximum incubation period of 7 days. Basically, when you look at it, these all viruses which are there result in an influenza-like symptoms which are there, but the major problem which can occur is shortness of breath, pneumonia and multi-organ failure. Well, lab diagnosis is to be done with RT-PCR. Rapid tests give false positives, and there is an inactivated vaccine for this particular 2009 strain, which is the A California 7 2009 H1N1. So we can prevent flu, avoid close contacts, social distancing. Social distancing is very important. Stay at home when you are sick. Cover your mouth and nose. Use a mask. Very important to use a mask. Keep cleaning your hands. Keep cleaning your hands. And avoid touching your eyes and nose. And practice other hygienic habits. So friends, stay safe, stay healthy. We will discuss about COVID-19 subsequently. However, if you have any queries, please ping me. You know my number. I'll take it down if you want to. 8185823503. I'll repeat. 8185823503. Do remember that though you people, many of you would not be seeing these classes, these would come in your exam. This influenza is a very important chapter for you, especially considering that COVID-19 is here to stay. It's a very important chapter in your exams. Do remember that immediately as soon as the lockdown is over, we will have your test for your internal assessment. Do prepare for your internal assessment. Stay safe, stay healthy, and read. Keep reading. It's a good time to keep reading. Thank you. How do I put this off?